Let me wrap up ARDS before we go to management. So besides the ABG, because the patient is in respiratory failure, remember ARDS is a progressive type of respiratory failure. Now, because of the nature of acute lung injury leading to increased capillary permeability, leading to water in the lungs. So that means the lungs are stiff, right? Very non-compliant, okay, poor or decreased compliance, meaning the lungs do not inflate and deflate normally because it's wet. It's not filled with air. Instead, it's filled with water. So it's very difficult to ventilate. And other findings to make the diagnosis besides ABG is the X-ray. X-ray will show white out appearance, meaning because it's filled with water, it's not going to appear black. It's going to be white. Okay, so it's like ground glass. You know, ground glass, when you crush glass into powder, it turns white, right? So regardless of the color of the glass, whether it's green, purple, when you ground that, it turns white. So the X-rays will look like that. So ground glass or white out appearance is classic feature of ARDS. So it's filled with water, very difficult to ventilate, very stiff lungs, very high resistance. So we will have to use a specific types of ventilatory maneuver or a different mode on the ventilator in order to ventilate these patients.
Yeah, really take out.
Well, the problem here is it's not like we poured water into the lungs. We did not. The water came from where? The capillaries. The capillaries are very leaky. Now, were we able to stop that in sepsis? Were we able to stop the leakiness of the capillaries? No, we were helpless, right? This is again, SIRS is a self-destructive response by the body to some serious injury, including acute lung injury, or like burns, for instance. So until that resolves, that water can never be, we will never be rid of that water, because although we can let the ventilator push air under positive pressure, push that water out back into the capillaries and therefore achieve gas exchange for a fraction of a second, right after, during exhalation, that water will go right back into the alveoli. Okay, so the only way to ventilate the patient is using a specific mode on the ventilator. Achieve gas exchange even for just a fraction of a second, get oxygen into the tissues, and then right after, during the exhalation period of the vent, the water goes right back where it was, goes right back into the alveoli.
Same thing as so in the burns, when the person got burned at the lung capillary
leak become leaky.
So
same exact, yep, the same. Regarding this one, because this is pulmonary edema, correct? If you think about it, yeah. You agree? Yes. The pulmonary edema this is another finding. That way, you know, the doctors know whether it's ARDS or heart failure. Because when you take an X-ray of a heart failure patient and an ARDS patient, put them side by side, it looks exactly the same. They appear white. You follow? Yeah. However, how do you know that this lung looks white, this one looks white? Is this heart failure or is this ARDS? Because is the treatment the same? No. Do you treat heart failure patients the same way as ARDS patients because they have wet lungs, both have pulmonary edema? No. They have two different treatments. Heart failure patients with pulmonary edema, what do you treat them with? Diuretics. They respond, the water disappears. ARDS patients, you give them diuretics, what will happen? Because what will happen to the patient's blood pressure? Drops. You keep giving them diuretics to lose water, that water won't disappear because more water will just come back and fill, because where did that water again come from? The capillaries, okay, because they're leaky. In heart failure, what led to the pulmonary edema? Was it leaky capillaries? What was it? Because it wasn't pumping, therefore there was congestion. So the water there was literally pushed out because of congestion. Clear? That's why they respond to diuretics, because once you remove the preload, you decrease preload. Of course, there's no more congestion, there's no more pushing, there's no more hydrostatic pressure, there's no more water to be pushed out. Okay, because there's no more congestion. Is there congestion here in ARDS? Cardiac congestion, that is. Is there congestion? No, there never was. Okay, the patient had what? They either had sepsis or drowned or aspirated, you know, all the causes that led to, they got burns. There were never congestion, correct? All right, so therefore the treatment is different. So that's another finding in ARDS. So granting this, what will be the BNP levels in an ARDS patient? Low or normal? Yeah, because there's no heart failure. Make sense? Okay, so these are the ways that doctors can order. That way they know, is this ARDS or is this heart failure? Okay, so the treatment is different. So appropriate, because what will happen again to a ARDS patient who receives diuretics?
Yeah, blood pressure.
Because remember, if you think about it, the lungs are wet, right? That means, is it easy for the heart to pump blood to the pulmonary arteries if they're wet? No. So is it any different from pulmonary embolism? What happens to forward blood flow? It also decreases. So cardiac output is also low in ARDS. So therefore, if cardiac output's already low, you give them diuretics, what will happen? It'll make it worse. Blood pressure will continue to drop. Make sense? Okay. So the diagnostic part is really, really important. Okay, we have to know, what is this X-ray? What are we looking at? Is this heart failure or is this ARDS? Because there's no way to tell based on the picture. So you have to do BNP. You have to do, you have to look at the nature. Okay, what led to this? What are the circumstances? Okay, are they responding to oxygen or not? Okay.
You see the position of the heart on the X-ray, and it looks like basically the lung is pushing the heart.
Well, both will do that though.
Oh, both.
Yeah, both will do that. Another is because these are critical care patients, obviously, right? So they're in ICU. Remember the pulmonary artery catheter? This is another way we can tell. Remember pulmonary artery catheter? The one they put into the neck and then into the pulmonary artery? What was that reading again? Now we tested you on PAWP and CBP. Central venous pressure or right atrial pressure was right side heart pressure, and PAWP or PCWP was left side. What do you think the reading will be? In heart failure, it was elevated, right? Because there was congestion. So the pulmonary artery catheter showed elevated readings. What will be the readings here? What will it be? Low or normal. Okay, because again, the pulmonary edema is not caused by heart failure. Okay, so a non-cardiac pulmonary edema. Make sense? Okay, so all these evidence, a BNP is low or normal. The PA, if the patient has a pulmonary artery catheter, it will also be right here. So the pulmonary artery catheter will also show low or normal numbers. Okay, low or normal pressures. Any question on diagnostic? Yeah, so we can also do troponin just to make sure, you know, it wasn't a heart attack that led to the heart failure. Yeah, that's another one. Okay, so management again is intubate the patient and put them on a ventilator. Let's just finish this part, although this won't make sense because we haven't done the basic yet. We haven't talked about what is PEEP or what is the FiO2 or, okay, let's go back to airway management under respiratory failure. So here's the management for acute respiratory failure, which is intubate the patient and put them on a mechanical ventilator. First of all, we do not intubate. Only advanced practice nurses, NPs, and nurse anesthetists can intubate, or respiratory therapists and all physicians. So our role here is to initiate the intubation, meaning notify the doctor that the patient is meeting intubation criteria. I mean, let's look at first who gets intubated, meaning when do you call someone that your patient now needs intubation. So here are a few indications. So the patients who are comatose, because can they protect their airway? No, they're unconscious. So whenever they aspirate, can they cough? No. So they could aspirate and die. Those who do not have the ability to remove secretions. So as far as comatose or unconscious, that applies to anybody. A stroke patient, depending again, if they're in a coma state, they need an airway, correct? Right. Of course, if we have patients undergoing surgery because we paralyze them, so can the diaphragm still move? No. So you intubate those patients and put them on a ventilator. Or let's say those who are breathing at high rates, let's say breathing 30 to 40 for the last several minutes. You think they can last any longer? Will they have infinite energy to do that? How can they do anything else if all their energy is expended on breathing? They're doing this all the time. Hour to hour, hour by hour. How long do you think they can last? Because can you eat when you're breathing like this? What do you do? No, you can't. You can only concentrate on breathing, right? So if you're in that much of a distress, intubate them, okay? They won't last long. So there are two ways to intubate somebody, through the mouth or through the nose. Between the two, we prefer the mouth. It's less traumatic compared to nasotracheal. Plus, if we go nasotracheal, that limits the size of the tube. We can't put in a large size breathing tube through the nose, can we? No, it's too small. So therefore, the mouth is preferred. So endotracheal tubes are the most commonly used airways. If a patient, however, requires mechanical ventilation and the airway longer than 2 weeks, we switch them to a trach. Are we clear? Because as long as the patient has an oral, an endotracheal tube, how will we keep them comfortable? Imagine you have an airway in your mouth. You can't talk, you can't eat, and this machine is forcing air into your lungs, whether you like it or not. Is that comfortable? No. So the only way to keep you from fighting the vent is to sedate you. Clear? Okay, so that's why if the patient, so therefore you can't eat, you can't talk, you're sedated. So how will you recover if you're in that state for longer than 2 weeks? So therefore, if your condition doesn't improve after 2 weeks, we switch you to a tracheostomy. Clear? That way, with a tracheostomy, we don't have to sedate you anymore because now you're conscious. You can even eat. Okay, you can eat, you can be out of bed, you can sit in a chair, still on a vent, but you're on a chair rather than in bed and sedated. Clear? Okay. So what is an ET tube? It's a plastic airway we put into the patient's mouth, throat, and then into the trachea. The tip of the tube, the end of the tube, must sit 2 centimeters above the carina. Where is the carina?
Right where
It's too high. Okay, so we have the trachea, right? And then it becomes the right and the left main stem bronchi, right? So that part right there, where it branches off, is the carina. So if you compare it to your legs, that would be the crotch, right? Yeah, that would be the crotch if you were comparing it to the trunk. So right where the right and left main stem bronchi divide, that's the carina. All right. Why should it be there? Because the tidal volume is the amount of air that the ventilator gives with every breath. You know, the how many ml of air. The tidal volume, is it calculated for only one lung or for both? For both. So therefore, if you put the tube too far, in which case it will only go to one lung. Which lung is that? The right or the left? Why the right? Not really.
It's higher.
The shape of the right mainstem bronchus is straight. What's the shape of the left mainstem bronchus? It's angled.
Yeah.
So therefore, a hard plastic airway, where's it gonna go? Can it make a left turn? It'll go straight. So therefore, it will always go to the right lung. Okay, the right mainstem bronchus, right? So therefore, the tip should not go beyond the carina. It should sit on top 2 centimeters above the carina. That way, when the ventilator blows the tidal volume, where will the air go? Divided into both lungs. Okay. Right. So 2 centimeters above the carina. So first of all, how do we know? Because we put in the laryngoscope. I mean, not we, the respiratory therapist or the doctor, we put in a laryngoscope to open the airway, then insert the tube. The whole process takes about 30 seconds. We call that rapid sequence intubation. So gone are the days wherein we have traumatic intubation. So right now, when we have a patient we need to intubate, the doctors will give you a muscle relaxant, basically a muscle paralyzer, rocuronium, becuronium. You've heard of those drugs? Okay. So that's a muscle, it's a neuromuscular blocking agent, paralyzes you so you don't move, so you don't fight. Nobody gets punched, nobody loses any teeth, okay? So the patient is paralyzed, we insert the laryngoscope, put in the airway, inflate it, 30 seconds later, finished, all right? Because right after we give you the, we can also use propofol to sedate you. Right after that, it takes a few seconds, 1-3 seconds, you're out, right? And then we can peacefully put in the airway. All right, so it's 30 seconds, plenty of time. So how do we know it's in the right place? We need an x-ray. However, how long will it take an x-ray to be done? Although we call the x-ray technician when we intubate, okay, when we call a code, for instance, we don't have to call, hey, x-ray, come here. No, when they call a code overhead, the x-ray knows to go to that floor, okay? So they go there and then they take the x-ray right away after 30 seconds. You know, they put in airway, take a flat plate x-ray, and then that takes 10 minutes though to develop, because remember that technician has to wheel a heavy machine down the hallway, press the elevator, go down to the radiology, develop the film, although everything's digital, but it takes time, okay? So how do we know it's in there? We won't, and we won't know exactly, but so does the patient wait therefore for oxygen?
No.
10 minutes for oxygen? No, we start bagging the patient. However, the easier way, but this will not confirm though, the 2 centimeters. We just know that the airway is, the plastic airway is in the trachea based on CO2 levels, okay? So we will put a capnometer at the end of the tube. Capnometer is a CO2 detector machine. If it reads, what's the normal CO2 level? 35 to 45, right?
Yeah.
So if it reads 35 or higher, where is the tube? It's in the trachea, because you won't see CO2 that high in the stomach. Make sense? Meaning if the tube is in the esophagus, the reading, CO2 reading won't be normal or high. It will be very low. Make sense? Okay. So we do the capnometer. We know it's in the trachea. We start bagging the patient. X-ray, we have to wait for the X-ray before we secure the airway. So until then, somebody will just be holding it, bagging the patient, or put them on a ventilator, doesn't matter. So as soon as it's in the airway, now someone has to inflate it, right? Why do we need to inflate the tube? This is the cuff right here. This is the cuff that will be inflated, and it has to be inflated at a certain pressure. There's a range that we use. How do we know we've already inflated it enough or not enough? We will have to listen to it. Now, whoever's intubating this patient will use a stethoscope, put it right here on the neck, right here, and listen. So right after this was inserted, we attached the capnometer. It's in the, we detected CO2, and then they will attach a, it's not shown here, but there will be another lumen here called the pilot balloon. So this is an endotracheal tube. This is a pilot balloon, okay? So we will attach a 10 cc syringe filled with about 5-6 cc's of air, and then we will slowly inflate the cuff until we don't hear a sound. Now, of course, at this point, someone's already bagging the patient, right? Giving a breath. Now, is there resistance posed by the lungs when you inflate? Yes, there is resistance. So you have to inflate it by force. So since if the cup is still flat, that means, is there a tight seal around the airway? No. So when you bag the patient or the ventilator gives a breath, will all the air go into the lung if this is flat? No, it will leak around. Remember, there's resistance, right? So the resistance posed by the lungs, the two lungs and the airway, the size of the airway, will force some of that air back out. So it will leak around here, causing a very loud, turbulent sound. Are you following? Okay. So the RT or the doctor listens with the stethoscopes, hears the leak, and then slowly inflates the cuff until the sound, the leaking sound disappears. As soon as that happens, you stop inflating, disconnect the syringe, and then the pilot balloon will now fill with air. Otherwise, it will appear flat like this. So this is a flat pilot balloon. This is an inflated pilot balloon. Not really. That one's flat too. Well, none of them are inflated because all of them are. This one's inflated, so the pilot balloon will have air in it also, right? However, you can't tell how much pressure is in here based on the size of the pilot balloon, okay? So how do we know how much pressure is in here? So we have to use a manometer. I'm just trying to explain because you're, yeah, we don't do this, but if your RT is not around, what are you gonna do? Well, my point is you have to know what to do, okay? Because this one you can do yourself. Okay, so this machine, this device, not really machine, this gadget will be hanging on the vent. There will be a clear plastic bag with some tubing with the manometer, okay? So the manometer will be in that bag, clear bag, tote bag, and then you simply attach the pilot balloon, this one here, you attach it to the side of this thing, and not seen here, but behind this will be a trigger. You know, a spray bottle? Spray bottle has a trigger, right? You used to spray, kind of like that. So you press the trigger, And as long as it's connected to the pilot balloon, it will give you a reading. Okay, so it will rise and give you a reading. How much pressure is inside the cuff? The pressure must be between 24 and 30 centimeters of water, or 20 to 25 millimeters of mercury. Are we clear? You follow so far? Okay, so that is the normal cuff pressure, endotracheal cuff pressure. Now, why does it have to be within this range? Think about it. If this is your trachea, is trachea living tissue? Does it have blood vessels?
Yeah.
What will happen if it's overinflated? It will strangulate the, it will cause ischemia and necrosis. If it's underinflated, it's going to leak air. So therefore, is your tidal volume adequate? Not if it's leaking out around the cuff. So we need the cuff to be tight enough, but not too tight. Is everybody's tracheal diameter the same?
No.
Can you say that between Philip's trachea and mine, do we have the same tracheal diameter?
I don't think so.
No. Okay, so we don't know what your size is. All we know is the pressure is between 20 and 25 millimeters of mercury, or 24 and 30 centimeters of water. So you can tell that here on the manometer. There are two sets of readings here. It can either be right here. You know, just like your car has MPH and KMH, right? So same thing. So either read millimeters of mercury or centimeters of water. Any question? So it explains here, high cuff pressure will do what? Tracheal bleeding, ischemia, and necrosis, whereas low cuff pressure will cause aspiration pneumonia and leaking of your tidal volume. Do you understand why it causes pneumonia?
Yeah.
Can this patient swallow?
No. No.
No, because the larynx is here. Okay, this is the larynx and this is the epiglottis. Can this muscle cover the trachea? No, because the tube is in the way. So this patient cannot swallow. Can they cough?
No.
Can't cough. You obstructed the airway. So therefore, do they have any control over the secretions from the mouth?
No.
No. Yes, it's okay if it runs down the esophagus. It's supposed to. However, do they have control protecting, keeping the saliva from entering the lung?
No.
No, this tube is in the way. So the only way to protect them from aspirating their own secretions is this cuff right here. Okay, this cuff stops secretions from going into the lungs. Now, what does your breath smell like in the morning? What do you think? So this patient has been intubated yesterday. So have they been brushing their teeth, washing their mouth, gargling for the past? No. So that secretion, is it clean or dirty? Very dirty. So that's why we will get to that, to the bundle, okay? Because of course this won't prevent ventilator-associated pneumonia 100%, but this will lessen the chance. Okay, so this proper cuff inflation, is this important? What are the reasons for ensuring proper cuff inflation?
Aspiration.
Prevent aspiration pneumonia and prevent tracheal necrosis, bleeding and necrosis, and
The tidal pressure, keeping it.
ensuring proper tidal volume, okay, or ensuring proper oxygenation. Any questions? Okay, let's continue.
Will this help the patient?
We'll get to that when we get to mechanical ventilation.
I wanna know.
So what are the two ways again to verify ET tube placement? X-ray and So the carbon dioxide, we call it end-tidal CO2, okay, or EtCO2, all right? Other ways to verify also is, I mean, you can tell, right? I mean, how do you know you're ventilating the lungs instead of the stomach? Which will rise? Of course, the chest will rise and fall instead of the abdomen rising and falling. How else? How do you know air is entering the lungs? Listen. Okay, so there are many other ways
What about
to
the
check.
Oxygen cell, O2 cell.
The what?
The O2 cell.
Not all the time, because remember, these patients are, you know, intubated for a reason, so you may not get a normal O2 sat right away. But when they're on a ventilator, that's the expectation though. So yes. So this is again the normal cuff inflation pressures. All right. So now the patient is, we have to secure the tube. That way it doesn't move, right? Okay. So we have commercial tube holders. Like this. So we don't use tape anymore. We used to use just plastic tape, but what does tape do? Break down skin, plus do they, because will this patient drool?
Yeah.
Yes, remember they can't swallow. So they'll drool, they'll sweat. So does tape stay on?
No.
No. So it will cause the tube to move. So therefore we need to use Velcro commercial tube holders. Okay, so they have nice silicone padding like this. It'll hold the tube, so this will lock in place, holding the tube in place. And then of course the Velcro straps make sure it doesn't move. Now, this is a plastic airway. Is it putting pressure on the mucosa, on the tongue, on the lips, on the gums? Yes. So does it need to be moved as well? Yes. We need to move it from side to side. Usually, if it's me, I would put it in the same spot as because we have to turn this patient, right? So we turn them right, left, and supine. So I do it the same way. So if I'm turning the patient left, I'll put the airway toward the left. Okay, that way I don't forget. Okay, where is it again? So just to make it everything simple, whichever side the patient's at, I put the airway there. All right. I just said every 2 hours, right? So you turn the patient every 2. You also move the airway every 2, and then you also do mouth care every 2. That way you just get it out of the way. Okay, every 2 hours, around the clock.
That magic mouthwash.
I know we have I'll show you in the lab next week. We have Q-Care kits. Everything you need to do mouth care is here. Remember, have you seen these? Notice in the left side of the rack, there's a whole box with these. You have to, because the when your units ventilator associated pneumonia cases rise, we know what's causing it. We're not doing mouth care. Are we clear? Yeah, and it's easy to track this because the supplies are ordered by the manager. So the central supply charges the unit how many Q-Care kits he delivered. Okay, and depending on the consumption, that means it will be tied. It'll be easy to trace. How many ventilator days do you have? That's calculated by the number of ventilator patients on any given day, multiply number of days, that's your vent days, right? And we know we have to use this every 2 hours. There are 4 in each kit. So how many are supposed to be used on one patient per day? If you're doing it every 2 and there are 4, 3. Make sense? There should be 3 of these kits every 24-hour period. So therefore, your vent days times 3 of these equals the inventory, right? How many you used up. So if therefore the manager sees I haven't been receiving deliveries. I had this many vent days. It's supposed to be this many. So does the manager know whether or not we're using it? Very easy to trace. And then the manager will just see, okay, who had vent patients? So it's between you guys. So who touched this patient? Who was assigned to this patient? Who had the ventilator associated pneumonia? So is it hard to trace? It's only between those patients who, those nurses who touch this VAP patient. So we call that VAP, ventilator associated pneumonia. All right, so you can't hide. It's very easy to trace. Because who's doing these? It's supposed to be us. So therefore, who's responsible for preventing ventilator-associated pneumonia? Nurses. All right, so don't take shortcuts. You're supposed to do that. Do it. Okay. So I already mentioned this, right? So if the patient requires intubation for more than 2 weeks, so we switch to a trach. Okay. So here, by which time a trach would be considered? So here are again all the reasons why we do not, we inflate the cuff, make sure the proper cuff inflation pressure is there every shift. We monitor that, we check the cuff inflation pressure. These are the rationales, okay? Tracheostomy, no different. The advantages here are, of course, the patients, you don't have to sedate the patient. Okay, they can be alert, you can assess them more. They're off sedation, they can be out of bed to the chair, they can eat, they can communicate, okay? They can socialize, they can get visitors, interact with visitors. And we just did the tracheostomy care and suction, okay? And you are tested on that this week. So here are your responsibilities. Do I have to read them? I mean, we already did these. I mean, we checked for breath sounds, right? We checked capnography and tidal CO2. We waited for, what should the x-ray show? Where should the tip be? Okay, very good. And do we check cuff inflation pressure?
Yeah.
How often? Okay, and then what should the pressure reading be? Or remember, there's millimeters of mercury or centimeters of water. You have to know the numbers. Is the cuff inflation, proper cuff inflation pressure, foolproof? I mean, is it guaranteed to not cause aspiration? No, so you still monitor the patient for aspiration. And because of this fact, we cannot guarantee that they won't aspirate from the saliva. So therefore, we know the saliva is dirty. So what should we do in order to minimize the dirt, the nastiness? Mouth care. How often again? Very good, children. Okay. Now the ventilator, of course, is a machine. So we are we breathing the same way right now as a ventilated patient? Because how are we breathing right now? Where is the air going through? Our nose, the nasopharynx, and the throat before it enters the lungs, right? So what is these airway structures doing to the air as they go in? Filter. What else? What is the warms it, and you said humidifies it, right? So the air is humidified, warmed as it goes into the airway. If we have an endotracheal tube, is that happening? No. What's the purpose? Why do we have nose hair? Why do we have humidifying? Why did God create this so that you don't? Because when it's dry, what will it trigger? Coughing, okay? Will trigger coughing. So therefore, how do we mimic that? So all air given by the ventilator must be humidified and warmed. Okay, so when it goes in, the air is also humidified and warmed by the vent. Now, you've seen our ventilator, right? So we have a series of circuits, correct? So these are the circuits connected to the vent. This one costs 60 bucks. Okay, so this is, can you see this? Okay, so this is the ventilator circuit. Okay, it's colored blue or sometimes white. Okay. So what will happen if you combine air, humidity, and warmth? What do you get? If you combine all three, moisture. Okay, so will moisture collect in the circuit tubing?
Yeah.
Yes, over several hours of, again, air, humidity, and warmth, it will produce condensation. There will be humidity, there will be moisture there. Can that moisture be large enough to pool?
Yes.
Now, if there's now water in the circuit, in the tubing between the vent and the patient, can that pose some resistance?
Yeah.
Meaning, as the vent blows the air through the circuit, but there's water, there's so much moisture there, it will trigger a high pressure or a low pressure? High pressure, because it's obstructing the flow of air, right? So that's one thing, one of the responsibilities you'll have as we go along. So ensure high humidity, and then make sure the if there's moisture that collects there, all you do is just disconnect the patient from the vent. Takes 2 seconds. Take the circuit off, drain the tubing, drain the moisture, and then put the circuit back on. All right? Okay, because is that clean
No, they can't.
moisture? No, that's nasty. Okay. Plus these circuit tubings, we don't change these every day. We change them only if they look nasty. Right? Otherwise, we leave it alone. Same one for 1 week. Okay, over a week, same thing. They typically don't, they don't get dirty that fast. Yes.
Yes, the good question. Alright, so the ventilator is a machine plug into to give the air. When you take out the ventilator, what's provided pressure? Or the ventilator?
It's the same, doesn't really change, because you just switch from through the mouth and down through the neck. They still have an
Oh,
airway.
you still gotta plug
Yeah.
the ventilator. So
Yeah.
you just using it.
Correct.
Uh,
Just a different airway. Make sure the FiO2, you can easily see it on the screen of the vent. So let's take a look at our ventilator. So the most popular type is the Draeger. So they had a large volume sale in 2020, 2021. So they become very popular. You see some buttons here. One, they're touchscreen. This one says O2 suction right here. So remember when you're hyperoxygenating a patient before suctioning. So all you do here is press this button, and it will hyperoxygenate the patient for 3 minutes, and you can just do your suctioning. Okay. I'll show you also a inline suction. I had one attached earlier. All right. So we need to secure the tube. Of course, we don't want that tube moving. Okay, we don't want that tube pulled out or pushed in, because we want it to stay where again? 2 centimeters above the carina. Now, there'll be a number documented on the chart. The ET tube has markings on it. You notice there are numbers here. There are lines and numbers. Okay, so this will be documented. We mark it at the teeth, okay, where it exits the mouth at the teeth. If the patient has no teeth, we use the lips. All right, so it's marked somewhere in the chart, and that will be your basis. So every day, every shift, you watch the placement of the tube because you need to verify tube placement every day, every shift. Is it still in the same spot? If it's pulled out or pushed in, you notify the physician, will adjust it. Okay, you don't adjust it yourself. Let the respiratory therapist, that's their job, or the physician adjust it. Are we clear? Okay. So these are all our responsibilities. Let's finish. The whether or not the patient will have a bite block depends on the patient's response to therapy. Usually when they start biting the tube, that means, are they okay? No, something is wrong. When they're biting that tube, that means, are they getting enough oxygenation? Could be that. Maybe it's a oxygenation problem. Are they sedated enough? Probably. Or are they comfortable? No. So you have to investigate what's causing the behavior. Okay, so you have to check oxygenation. If that checks out, okay, ABG looks fine. Is it my sedation? Oh, my propofol is empty. Okay. Or is the patient possibly in pain? Is your fentanyl or morphine drip still going? Okay. So you assess, investigate what's causing the behavior. Okay, so they're not supposed to be doing that, right? They're not just doing that because they want to. Okay, so there's something wrong. If needed, then the doctor may order. If you checked out everything, oh, they're fine, probably dreaming or whatever, so you can put a bite block. Okay, just like with the dentist, okay, they put a bite block, keep them from biting that thing. But you still investigate. We suction how often?
As needed.
As needed only. Okay, no routine suctioning, because what will suctioning do every time you do it? Yeah, it'll cause hypoxia, right? That's why we hyperoxygenate before, during, and after the suction passes, correct? Because it will cause hypoxia. Plus, what will it do to the mucosa? It will damage it. It will cause trauma. Okay, so too much suctioning. So we never do routine suctioning. They don't need it. Leave them alone. Okay, we'll get to the indications for suctioning later. I already mentioned was turn the patient every 2, do mouth care every 2, and move the airway every 2. Since this is here, let's just finish the extubation as well. So let's say later, 3 days later, the patient got better. Okay, so and of course, before this happens, we already wean the patient. We'll talk about ways to wean the patient a little bit later. So this patient is already obviously off sedation. Okay, we've done our spontaneous breathing trials. They passed, so they're ready for extubation. So we'll tell the patient, okay, so we're going to give you oxygen, lots of it. We'll hyperoxygenate you. We will have to suction you first, and then we will quickly deflate the cuff and then pull out the tube quickly. We want you to cough, okay? We want you to cough like crazy. This is what's gonna happen. Look at the placement of the airway. When we suction, what are we really suctioning? Which part? Where are you suctioning? Are you suctioning here?
Yeah.
Or here?
No.
Here, right?
Yeah.
Are there secretions here?
Yes.
Can you reach it?
Yes.
No.
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 So
So there are.
You want to be doing this upward?
Remember,
You're inside the tube, you're in the
catheter is
tube, bro.
inside here.
You're in the tube. You're not outside.
Okay. So when you insert the catheter, the suction catheter, it's inside the ET tube. So there's no way you can
Yeah.
suction this section here. So are there secretions there? So when you deflate the cuff, what will happen to those secretions?
Go down there.
They'll go down straight to down. So that's why when we tell them, I'll quickly deflate, pull out the tube, what do we want them to do? Cough like crazy. Okay, so we don't want them aspirating that. So we want them to take it out. However, some hospitals, not all, has a ET tube like this. So this is the ideal for me. All ET tubes should be like this. So this one, remember, most ET tubes has 2 lumens, right? The ET tube and that pilot balloon, the cuff inflation port. This one has 3. The third one is a suction port. Allows you to suction this area here. So there'll be a third lumen that stops right here. And there will be holes here, allowing you to attach suction here and suction this. We call this a subglottal area. Okay, so if we have a tube like this, very easy. You're suctioning the subglottal area. You just attach it to suction and press the suction button. It'll take out all that suction above the cup. Okay?
They don't have four.
No, because we already sucked all that out. But again, not all hospitals use that. I don't know why. It couldn't be any more expensive, than a couple bucks. And this is what you do after extubation. Please read. These are self-explanatory. What do you do? There's a chance that they will have some pain because of course there was the tube, right? So there's some trauma there, irritation. Just monitor them. These are complications of a plastic airway, not just a tracheostomy. It's any artificial airway. Okay, so there's laryngeal nerve damage, could be subcutaneous. Subcutaneous emphysema is air in the subcutaneous layer. It's done whenever you make an incision on the thorax. So any incision done from the neck down to your above, below the rib cage, this area right here, tend to attract air. It's because of the negative pressure of the chest. So when you make any incision, like a chest tube, for instance, or let's say open heart surgery, so air tends to seep into the subcutaneous layer. That's called subcutaneous emphysema. So here are the complications: rupture, fistula, tracheal dilation, especially if the tracheal, the cuff inflation pressure is too high or too low. Too high, very good. Or stenosis. Remember the presence of the airway and the cuff, will it cause inflammation? Yes, it can cause tracheal swelling as well. So that's why we need to check the cuff inflation pressure every day, every shift. Because the diameter size can change, okay, because of the inflammation. So the more inflamed, what will happen to the diameter? It will narrow, okay? So therefore, do you need more or less inflation pressure? Less. Okay. So again, that's the reason for the checking cuff inflation pressure every, how often again? Every 6 to 8 hours. Is it done regularly? Probably not in practice, but for the NCLEX, how often do we do it?
8 hours.
6 to 8 hours. So never compare actual practice with the NCLEX, okay? NCLEX, stick with the textbook. I know it's not done that often. Guilty also sometimes. He gets busy, he gets busy. You forget, shit. And then when I remember, I do it, but these are the same Remember, on an intubated unconscious patient, can they tell you what's wrong?
No.
So how's the only way you can evaluate whether or not your patient's oxygenation is adequate?
Accident.
ABG. Okay, so draw ABGs. How often do you think we'll need to do that?
Well,
As needed. Okay, whenever you need to. You suspect something's wrong? Okay. If you're in ICU, it's okay because they have an arterial line. So you can just simply draw all you need is an order. Ask the doctor, hey, I need you want your report, your suspicion. Can I get ABG? Okay. You can draw it from the arterial line. If not, then RT will do it, or the doctor will come draw the ABG for you. We don't do arterial sticks, okay? We can do IV sticks, but not intra-arterial
Dr. Sibu,
or an RT. Okay, we already talked about the cuff inflation pressure. Okay, so what are your responsibilities regarding the cuff? The endotracheal or tracheostomy cuff? Proper cuff inflation and that suctioning, okay. What do you inflate it with? Air, okay? Don't put saline because what will happen if you put saline and that cuff ruptures? Aspiration. Okay, so only air. Okay, I'll start the mechanical ventilation next week.
Thank you for